Hi everyone, I'm Stephen. So I'm a neurology registrar from South Australia who's currently in Boston, where it's about 3 in the morning, and I'm going to be presenting on immunology. So make heads or tails of that. So this is what artificial intelligence gives you when you ask what a penicillin allergy looks like. And I think it's appropriate. It looks a bit like a manacle, although its spelling was a bit off, in that when someone's labeled with a penicillin allergy, it tends to stay with them and it disadvantages them. We know that people with penicillin allergies get slower antibiotics and sepsis, more C. diff, more readmissions, multiple worse outcomes. But not everyone with the label of a penicillin allergy, in fact, is allergic to penicillin. A lot of them are actually intolerant, which is a non-allergic reaction. Now, we know that up to about 10% in the electronic medical record is wrong in terms of allergies and intolerances for penicillins. So we first off looked at our population, see, does the allergy versus intolerance label make a difference to prescribing? And it does, unsurprisingly. People who have an allergy as opposed to an intolerance are getting more cefepime, more ceftriaxone, more vanc. So it's a significant distinction. So the question was, how can we go about trying to fix all of these incorrect penicillin allergy labels that should actually be intolerances? So we used artificial intelligence. So first off, I made an algorithm that read the words in the EMR to distinguish whether penicillin allergy was an allergy or an intolerance. And you can see that receiver-operator curve. Normally, when you get a result like that, you think you've done it wrong. You know, I've done something wrong here. That's too good to be true. So we then tested it on a different data set. So each of these is about 10,000 patients, a lot of manual labeling, and it validated. So the artificial neural network, again, came out with an area under the receiver-operator curve of almost 1. So it was almost perfect as compared to a gold standard of an immunologist labeling. And we actually validated this on a couple other populations as well, including specific surgical ones, but they didn't all fit on the slide. But then we want to see, can we make it better? Because, you know, maybe it's great for all the common things, but what about, you know, SJS, or what about, you know, TEN or DRESS? These things are uncommon, these are rare. So we use synthetic data and then an approach called transfer learning, where you take one model and shift it to another place, and actually found that that made the algorithms perform better, which is exciting, but now it's time to actually use them. So in our first implementation study, which is led by Brandon Stratton, who's a BPT pictured here, we use the algorithms to read the EMR once a week, and then took a group where they got an email and then everyone else didn't get an email, and looked to see who got delabeled. And more people were delabeled in the group that got an email than the other group, because no one got delabeled there. So that was cool. I mean, that's made an impact. That's hopefully improved some people's access to antibiotics. But I'm not sure about you, but I think doctors sometimes don't read their emails as closely as they should. I know I'm a bit slow online at times. So we thought we could do better. And that's where we're up to now. So we were lucky to win a grant for this. So we've got a funded drug allergy RMO who is going around proactively delabeling people. So we've got the algorithm reading the EMR for all the inpatients every day. It finds people with spurious penicillin allergies. They go and take a standardized history. Sometimes they can directly delabel them, and sometimes they have a penicillin challenge, which is part of the protocol that we're investigating. And we've now delabeled around 50 people, a bit more, and no one's had an adverse reaction yet. So hopefully that's 50 more people who can access first-line antibiotics and save the healthcare system some money as well. And we're really keen to take this on the road. We think this is helping patients. So it's now going to other centres in South Australia. And if people are keen, we'd really like to take it to other centres too. And I'm probably going to go to bed after this talk. So I hope you'll forgive me if I don't hang around too long afterwards.
Thanks so much, Stephen. Sleep while you can, but we do have 2 minutes of questions before you put your head down. So any questions from the room?
Would that work with any electronic record, or what one was it used with?
Yeah, so we have something called Sunrise in South Australia, and the text should be EMR agnostic because it's just text, right? Some of the allergies are wild. Like my favorite one is a bloke said that his skin turned like a shingleback lizard. Classify that as an allergy or an intolerance. It was an allergy. But The text should be EMR agnostic, but how to get the text out of the EMR takes a bit of thinking.
Any other questions? Graham,
Was I looking questioning? I'm very impressed with work. Does Sunrise rely on a narrative to record the allergy, or does it actually have it as a flagged event? For example, as I know it in Epic.
Yeah, so it's a good question. So it has both.
Yeah.
So the way that people enter allergies and intolerances in Sunrise is there's a tick box and a free text box. And most people seem to do both.
in the interest of your sleep, Stephen, thank you so much.